Hello, welcome to Learning at Lunch and this session on toxicology. My name's Dr. Laurence Gray. Pleased to have you with us, and I'm the Medical Director of NPIS Cardiff. I'm going to talk about three things today: low toxicity substances, toxidromes, and carbon monoxide poisoning. It's important to say that potentially everything is poisonous, and it's often a matter only of dose. And as Paracelsus says, all things are poisons, nothing is without poison. The dosage makes it a poison or a remedy. I think a good example of this would be something like table salt, which of course we consume most days. But if we take too much, it can be significantly harmful. I think this is the point to say United Kingdom NPIS provide a telephone line for advice 24/7, 365 days a year. The number is there. So we're always happy to hear from you. In terms of low toxicity substances, all substances can be potentially dangerous, as I've just said, but some, to paraphrase George Orwell, are less dangerous than others. Mild gastrointestinal upset, something you could see, but it's important also to say that should symptoms be prolonged, or there should be concern, that it's worthwhile seeking advice. And we always say, if in doubt, give us a call. Examples of low toxicity substances would include something like ballpoint ink, pencil lead, cough sweets, tinsel to be seasoned, and something that's quite common we see would be silica gel, the desiccant, in things like shoes and clothes. All of these unexpected to cause significant toxicity. Here's a poster. It's quite small, but just gives you an idea about all these substances. And this is something that we have produced as a resource here at the NPIS, just to give guidance to healthcare professionals about these low toxicity substances. Toxidromes. Well, what is a toxidrome? Well, they're clinical symptoms and signs grouped together that give suggestion of what a potential poison could be. Often we find that in managing these patients, we don't have a test that's going to make the diagnosis for us. We have to take the constellation of signs and put them together to come up with a diagnosis to allow treatment. In opioid poisoning, we have causative agents would be heroin, codeine, morphine, but also think about therapeutic agents, tramadol, fentanyl, methadone. We often think about opioid poisoning as a drug of abuse, but it's also important to remember that for some people it's an essential part of medication to allow them to live with as little pain as possible. Sometimes that boundary is crossed. The diversion of medicinal opioids onto the street is a matter of concern in many countries. In terms of the toxidrome, what do we see? Well, we see this patient who's got a reduced conscious level, decreased GCS, classical coma scale, low respiratory rate, slow breaths, small pupils, pinpoint, low blood pressure, but also a response to naloxone, the antidote, the antagonist, which we should be very rapid indeed. It's important at this point just to highlight that in our two groups of patients, if we are thinking of administering naloxone, in those patients who need it for therapeutic help, we don't really want to go in with a high dose. And certainly an NPS would suggest a lower dose, maybe 25% dose of 100 micrograms to be used initially, because we don't want to really bring the patient all the way back to conscious level and remove all their pain control. And unfortunately, there have been national patient safety alerts regarding this. However, in a situation where someone is comatose on the street or being brought into a resus department who has maybe abused the drug, then often we'll use a higher dose just to bring that patient up a little. But once again, it's not necessarily bringing them to full consciousness, but just enough to avert those worrying possibilities of loss of airway control and lack of respiratory drive. Anticholinergic toxidrome is also something we should be very mindful of. Many of the medications that we prescribe to our patients will have anticholinergic effects, And many of you here will be aware of the potential deleterious effects they can have on our elderly population. It's also important to say that there are some natural sources, Jimson weed, atropine, also known as belladonna, because it makes the pupils big. In this past, this was seen as a very attractive feature. And also Amanita muscaria, that lovely red and white toadstool. In terms of the anticholinergic toxidrome, what we will see: confusion, agitation, the large pupils, as I said, dry mouth, urine retention, often described as the phrase red as a beet, dry as a bone, hot as a hare, blind as a bat, mad as a hatter, and full as a flask. Important to remember these because, of course, many medication have these effects. So if a patient has persistent dry mouth, or has gone into urinary retention, or maybe their bowels are a little bit sluggish, it may be well worthwhile just thinking about the anticholinergic combination of their medication. I've put a little list here. These slides will be available at a later date. I won't go through it all, but it's important when we think about our prescribing, we always consider this anticholinergic burden. In terms of cholinergic toxidrome, less likely to see this, but responsible things would include organophosphate, insecticides, nerve agents, and potentially nicotine as well, to name but a few. And this is kind of the opposite. The patient is kind of excreting all these secretions, salivation, respiratory excretions, vomiting, diarrhea, urination, defecation, and the small pupils. So sometimes it is potentially able to be confused with the opioid toxidrome, but it's important that you've got this hypersecretory state, which is pathognomonic. In terms of the serotonergic syndrome, it's really important to bear this in mind, as this is often due to polypharmacy and potentially can happen iatrogenically. We do see it in acute overdose. Essentially, we've got to be careful, particularly about control of temperature. Here I've put a table with a few kind of examples of medications that can potentially lead to the serotonin syndrome. And of course, as I said, if these medications are given together, that in itself can provoke. So how does it look? Well, increased temperature is a worrying feature and should be controlled. Confusion, an agitated patient, bruxism, this kind of clenched jaw, is very typical. Hypertonia, so rigid, but also clonus is very, very commonly found in the patient. They may also have bladder and bowel symptoms. So important to be aware of this, and temperature, if left untreated and very high, can unfortunately lead to denaturation of body proteins. I just want to speak briefly about carbon monoxide poisoning. We're moving into the season where we may see a little bit more of this. It's important to say, because it's colourless and odourless, it's very dangerous, and also it is possible with chronic exposure to be very much insidious in onset. Often we talk about boilers as being a source. It's important to remember, though, that generator use in poorly ventilated areas, the use of charcoal grills inside the house or in tents, and even camping stoves and lanterns may contribute to carbon monoxide poisoning, be potential sources. How does it have its toxicological effect? Well, essentially, carbon monoxide has a 250 times greater affinity to hemoglobin than oxygen, occupying the binding sites on the hemoglobin molecule, stopping the ability for oxygen to be transported and offloaded around the body, inducing tissue hypoxia. In terms of percentage of carboxyhemoglobin, less than 10% is likely to be asymptomatic, but of course, as the percentage of those occupied blood cells increases, then so does the symptoms. In terms of management, well, the most key thing is to remove the patient from the source, using supportive measures A, B, C, D, and E, utilization of cardiac monitoring, and high flow oxygen. As you can see in the table below, if high flow oxygen is used compared to room air, the half-life of carboxyhemoglobin is reduced from 5 hours to 1 hour. I also wanted to draw your attention to this resource, which is incredibly useful and is the UK Teratology Information Service. So this is a service that offers advice to healthcare professionals who think that a pregnant patient may have been poisoned or adversely affected, but it also has monographs on treatments used in pregnancy and the evidence about safety of various treatments. Furthermore, the bumps component to the UK TIS, UK Teratology Information Service, has some patient information leaflets regarding medicines in pregnancy. It's also important to say that this website is being updated, and I believe is going to be a new website is going to be launched in the next couple of weeks. With the new website, you will be able to register if you have an NHS address and be able to access all the resources contained within. I would highly recommend using this resource both as a prescriber and potentially may need to treat a pregnant patient. It really is a fantastic resource. I know it's been a short little tour of the world of toxicology today. I really do hope that you've found it interesting, and really would love your feedback if you think there's any more topics regarding toxicology which you think would be useful in your day-to-day clinical practice. Thank you so much for your time today. I'm online now and ready for your questions. Many thanks. Bye now.